Okay, so I did my presentation on cancer pain management, the assessment, treatment, and prevention strategies. What is cancer pain and why is it so hard to manage? Cancer pain is hard to manage because it can be a diffuse or a localized pain, it can be acute or chronic pain, or it can be all of the above. The primary concern for patients who receive a cancer diagnosis is typically the fear of pain, seeing as 60 to 90% of patients with advanced cancer disease experience severe to moderate pain. The overall goal for nursing management of pain is to increase the quality of life and optimize function in this state. Etiology of cancer pain. Pain can be related to pressure from the tumor, underlying diseases, diagnostic procedures, and the cancer treatment themselves. Nociceptors are our body's pain receptors. They are found in the skin, joints, connective tissues, blood vessels, periosteum, skeletal muscle, fascia, tendons, most of our visceral organs, and the corneas. These receptors are stimulated by insult to the tissues, which then results in the release of chemical mediators. In turn, nociceptors activate the nervous system to respond, react, and remember this pain. Prostaglandins are also used in this mediation reaction, and they actually enhance the bradykinin receptors to enhance your pain response. Sensitization of cancer pain occurs when C fibers are stimulated in response to slow twitch or delayed pain. This is usually part of the chronic pain pathway. The more often the C fiber is stimulated, the more intense the response becomes. Therefore, a smaller stimuli generates a much, if not more, painful response than previously experienced with larger stimuli. Because of this phenomenon, sensitization of pain occurs. Cancer pain can be acute or chronic. Most often, the acute pain is due to surgery, treatments, or trauma. In chronic pain cases, pain is usually due to tumor growth or metastasis, or it can be a secondary injury due to surgery, tumor growth, or treatments. Pain can also manifest in different locations for different reasons and differ and change over time. The patient may have chronic cancer pain, then also experience an acute episode of pain in the same area, different areas, due to secondary injury or underlying illness or disease. Nursing assessment of cancer pain. A thorough assessment of the pain is done using the OLCARTS method. OLCARTS stands for onset, location, duration, characteristics, aggravating or alleviating factors, related symptoms, treatment, and severity. Doing this, you also want to assess how the patient has managed other pain in the past and if they had cancer pain in the past and how they've managed that. If the patient seems to be in pain but also reports no pain, you want to further investigate this patient. Physical and psychological aspects of pain. How the patient perceives pain can also affect how it is managed. A patient is eliciting symptoms of fear, anxiety, fatigue, anger, social isolation, and previous events of poor pain management. They are likely to have worsening factors of pain. Psychological effects of pain management can manifest as personality changes, mood swings, decreased functionality, and loss of self-reliance. You want to identify how pain is affecting the patient's lifestyle and what their goals are for effective pain management. These are some nursing diagnoses related to cancer pain, both acute and chronic pain, as well as some outcomes you want to identify for your patient. So acute pain can be related to a neoplasm, chemotherapy agents, surgical interventions, surgical site pain, irritation to radiation of the skin localized to the radiation. Chronic pain can be due to an injury agent like chemotherapy, malnutrition, nerve compression, and tumor infiltration or metastasis. Planned outcomes for this patient. You want the patient to identify current pain levels and establish a functional pain goal. And this should be done during your assessment period and then identified as your planned client outcomes. The patient should also report meeting functional pain-related goals once you decide and identify these pain goals and possible relief of pain. You want the patient to state the ability to obtain sufficient amounts of rest and sleep and minimal side effects of the pain reported. You also want the patient to describe non-pharmacological methods that can be used to supplement pharmacological pain control methods and the use of these methods to be effective in their care. Treatment. Non-pharmacological approaches. Because of sensitization to pain, pain must be addressed as soon as it's noted or reported. Patients require less medication and experience a more effective pain relief if analgesia is administered before they become sensitized to the pain. The treatment of pain often requires multiple approaches in the intervention prior to the report of pain. Some interventions you can use are to create a quiet environment, use comfort measures like massage, acupuncture, positional changes for the patient, hot and cold compresses, transcutaneous electrical nerve stimulation. You can use guided relaxation techniques, meditation, breathing exercises, music therapy, and hypnosis. Also, you can use distraction techniques with like diversional activities through like watching TV or something like the latter. Treatment for cancer and pharmacological approaches. These approaches include opioid analgesics, NSAIDs, local anesthetics, and antidepressant and anti-seizure medications. The WHO pain relief ladder is what practitioners use in order to give appropriate medication therapy. So we start at like the lowest tier and move up depending on the patient's response to the medication administration. The most common medication used for cancer treatment is opioid analgesics. However, these have a lot of, although they are very effective, they have a lot of adverse effects, most notably causing respiratory depression. But more commonly, or more annoying to patients, it's going to be the nausea and vomiting and constipation. And we'd have to give antiemetics and like Colace or something like that to help with these patients as well. It also can cause urinary retention, decreased testosterone levels, accelerated osteoporosis, and then you want to watch for tolerance, addiction, and the possible ineffective dosing. Sometimes practitioners or patients themselves or family members are less likely to give opioid medications at a dose schedule because they're scared of tolerance and addiction. So this has to be monitored. NSAIDs are also used for cancer pain management. They're often used with opioids to treat pain more effectively than opioids treating alone. Therefore, you have to have a lower dose for the opioid analgesic medication when substituted with NSAIDs as well. Adverse effects for NSAIDs include GI upset, kidney dysfunction, and elevated bruising. Local anesthetics are used directly at the site of injury, and this is to block nerve transmission from the site of injury. This is often used in like surgical interventions. You can use this anesthetics and epidurals, and you can use it when you have to do a lumbar puncture. And then lastly, antidepressant and anti-seizure medications are used for neuropathic pain, which is not alleviated by opioid medications. You want to make sure the patient knows that there are a lot of adverse effects for both these medication types, and that with antidepressants, they may not have results for about 4 weeks. And anti-seizure medications also hold a myriad of adverse effects as well. Breakthrough pain is also very common, and it is a sudden increase in pain, even though constant pain management is being used. So you're going to have a patient who is basically on round-the-clock NSAID or opioid analgesics, maybe antidepressant medications in order to control their cancer pain, but they also will have breakthrough pain periods where they'll have like a PRN opioid in order to treat this pain. Management and palliative care. Palliative surgery is used to relieve symptoms of pain due to the cancer growth when curing the cancer is no longer possible. This is obviously an invasive procedure and it has a lot of complications. So there also may be pain secondary to the surgery. So a patient that goes under palliative surgery must be advised and consulted and educated appropriately prior to undertaking this type of treatment. When the patient is no longer able to communicate pain management needs, any signs of pain should constitute additional pain medication administration. So this patient who is nonverbal, we're going to assume that they have pain if there's any types of signs or symptoms in a palliative setting. Examples of nonverbal pain communication would be grimacing, tachycardia, tachypnea, restlessness, poor sleep, and a decrease in function. Of cancer pain management. When you evaluate someone with cancer pain or any pain, you want to use consistent pain scales, and you want to use assessments that can identify the effectiveness of the pain management. A standardized scale would be the best option, and you want to make sure that you keep that same scale each time you evaluate and assess the patient. Evaluation of pain management techniques should be an ongoing and frequent process. They say that pain is the 5th vital sign, and however, we don't take vital signs every 30 minutes to an hour like we should be reassessing pain at those intervals. So You want to actually do it more frequently than use size vital signs on these patients. You want to especially make sure that you are checking in those patients who cannot self-report pain. You also want to go back to determining your manageable pain score with this patient and make sure that's a constant goal that you're meeting. Pain is a different meaning indication that is personal for each patient. And you want to work with your patient, understand what this pain management and how to continue managing their pain actually means to them and their lifestyle. If pain management is inadequate, the nurse must continually advocate for improved or different treatments. So this might mean going to like the practitioner or the physician and advocating for change for your patient, maybe different medications, maybe higher doses, maybe some like therapeutic interventions that are non-pharmacological as well as pharmacological interventions. Evaluation also must include further assessment of adverse effects of pain medications or therapeutic interventions. So you're looking at your nausea, vomiting, constipation, any GI upset or effects of your NSAIDs, and so on and so forth, as these can actually hinder the therapeutic pain interventions. So changes in practice, prevention strategies, and patient education. You want to encourage patients and their families to take active roles in the prevention and management of their pain. Often patients fear opioid use and dependence, and this creates hesitation in dosing themselves, their family members, or whoever, or accepting medication due to this. Once the patient learns how to manage their pain, it can actually reduce the psychological effects of anticipated pain, like anxiety and such, and resulting in actual pain reduction, which therefore results in a lower dosage of pain medication. You want to teach the patient to report or intervene as soon as pain is felt to reduce the chance of sensitization to pain medication or sensitization to the pain stimuli. You want to use set intervals to administer pain medication or PCA pumps, and this will prevent medication serum levels from dropping. Individualized dosing is something that needs to be advocated for as well for your patient. You want to conform the dosing to the patient's needs, not just a blanket baseline dose that may be subtherapeutic or can even cause an overdose in your patients. Use of other medications and control of the side effects, again, is warranted to produce the improved therapeutic effect of medication as well as medication compliance. Some NCLEX tips for cancer pain management and cancer in general. So nursing diagnosis related to pain here. There's also some that can be related to the cancer itself. It depends on what it's related to and is evidenced by for each patient. Notably, obviously, acute and chronic pain, ineffective coping, disturbed sleep pattern related to the pain, activity intolerance if they're unable to move because it's too painful, and self-care deficit, much the same if they're unable to take care of themselves related to their pain. You want to use non-invasive methods for pain management when possible. So you're looking at your non-therapeutic interventions like we were talking about earlier. Interpersonal skills on this one. If you want to like be able to talk to your patient and kind of increase your therapeutic communication styles. It's a helpful non-invasive method for pain management for these patients. I found something that's kind of cool with the 7 warning signs of cancer as noted below. So obviously we know the ABCDEs of melanoma. It's kind of been drilled into us, but the other ones are kind of more vague symptomologies that could be related to cancer, which I thought were pretty cool to note. Some general definitions and tumor tissue origins are noted below, just for some help in NCLEX studying. References, all of which are books that we have. So if you guys have any more questions, you can either email me or find them below.